Good evening, everyone. I'm Dr. Neil Gopi Singh, presenting from Port Spain General Hospital, Neurosurgery Department. I'll be presenting tonight the 2021 WHO Classification of CNS Tumors update. The objectives of the presentation, by the end of it, we should be able to understand why the WHO CNS classification was updated, recognize the shift towards molecular diagnostics, identify major changes in glioma classification, understand updates in pediatric CNS tumors, and appreciate the clinical implications for prognosis and treatment. So this is just a snapshot of the updated books over the years, and you could see it started off in 1979 as the classification of CNS tumors, and is now the 5th edition in 2021. When it initially started, it was purely histological classification. In 2016, there was the integration of molecular markers. That's where it began. And the latest edition being 2021, where the restructuring of the molecular profiling became the mainstay. So CNS5, the 2021 edition, builds on 2016 WHO update with C-impact now recommendations. As I said before, there's a major shift from the histology-based to molecular integrated diagnosis. The key concept is molecular features now define many tumor entities. So what is C-impact now? Basically, the WHO Blue Books or the tumor classification books are updated every 5 years or more. Between 2016 and 2021, there was a vast increase in molecular discoveries, especially with respect to DNA methylation. So a group of top neuropathologists formed a community or group called C-Impact Now, which was a consortium to inform molecular and practical approaches to CNS tumor taxonomy. They published a series of updated scientific journals, and this was used in the production of the newest update of the WHO CNS tumor guidelines. So there were some major conceptual changes, mainly being that of integrated diagnosis. So what that is the combination of histology, molecular genetics, and the WHO grade. An example would be astrocytoma, being the histology, IDH mutant, the molecular genetics, and the WHO grade 4. Molecular markers can override histology. For example, if you were to have a IDH wild-type diffuse astrocytic tumor with TRT promoter mutation and EGFR amplification, as well as +7 -10 signature, that would be automatically classified as a glioblastoma, despite having a histology that may be ambiguous. Also, the Arabic numerals were replaced with Roman numerals, so we have the number 2 instead of Roman numerals 2. So what benefits this new classification pose? Histology alone had inter-observer variability. Tumors with identical histology also behave differently. So there was poor prognostic accuracy and limited guidance in terms of treatment. Advances driving the change were the IDH mutations, 1p19q codeletion, H3 mutations, and DNA methylation profiling. What this improved was diagnostic precision, prognostication, trial stratification, and targeted therapy selection. So this is a table showing showing the main key diagnostic genes and molecular profiles, right, in correspondence to the tumor types, and is pretty extensive. I'll go into some more detail of it and break it up into sections later on into the presentation. So This is just, I picked out some of the important ones to highlight. So IDH1/IDH2, that marker, basically they will have wild type or mutant. And what that would give us information about is the type of tumor it would be. So it would indicate astrocytoma versus oligodendrogliomas or ruling glioblastoma architecture. The 1p19q codeletion, that would be specific for oligodendrogliomas. Um, so again, TP53 mutation, that's lineage support, and that would basically tell you that the tumor is of the astrocytoma lineage. Um, Interesting to note would be the TRT promoter. Basically, that would automatically, along with other molecular markers, um, class the tumor as a glioblastoma grade 4. And these are some other noteworthy molecular markers. We mentioned the +7 -10 signature as well. Um, PIT1, TPIT, SF1, those are specific for pituitary tumors, and they basically correlate to the hormones that the pituitary tumor would secrete. So with respect to the DNA methylation profiling, right, this is a transformative epigenetic platform that identifies tumor by their stable molecular fingerprint. And how that became useful, well, it has two specific or two main uses. So the Heidelberg classifier, this was developed by the German Cancer Research Center and Heidelberg University Hospital. And what they did was, based on that fingerprint, they were able to create an AI, artificial intelligence, to correlate it against 100 reference cases. And they have a score from 0.0 to 1, and a score above 0.9 would basically be exceptionally reliable, and it would definitively be a molecular match. So it's crucial for categorizing undifferentiated or atypical tumors that would evade histological examination. Is also gold standard based on that definitive molecular match. However, there are limitations involved, of course, which range from being costly as well as limited availability globally. The other use would be for the MGMT promoter status. And what this basically explains for us, or gives us insight to, is if the tumor would be susceptible to temolizumab chemotherapy. So if the gene was found to be methylated, which would be that it switches off, it would mean that there's a low DNA repair protein production, and that would mean that it's sensitive to temozolomide. If it is on, that means, well, that would be an unmethylated DNA segment, and that would mean that it would be resistant to the alkylating chemotherapy. So this would be basically useful when utilizing STUP protocol to predict survival rates for patients, especially elderly patients. So we mentioned IDH status before, and the importance of the status is basically there are two types, the wild type and the mutant. Mutant is when there's a change in the normal genetic makeup of the tissue, whereas wild type is that it basically is normal. And normal is negative in this regard, because what that means is that the tumor cells, they would continue to replicate because there's no damage in the genetic makeup of it. So it will be more aggressive. So that also gives information with respect to survival and also treatment. So what is IDH? That's a metabolic enzyme mutations being IDH1 or 2. And we explained the diagnostic importance with the markers that it distinguishes between astrocytoma, oligodendroglioma, and glioblastomas, as well as the prognostic value. So the major themes of the WHO CNS5, the key changes were it had greater molecular integration, new tumor families, and new grading approach, separated pediatric and adult gliomas, and there was a new nomenclature and laying reporting. So with respect to gliomas, glioneural and neural tumors, it divided this into 6 categories: adult type diffuse gliomas, pediatric type diffuse low-grade gliomas, pediatric type diffuse high-grade gliomas, circumscribed astrocytic gliomas, glioneural and neural tumors, and ependymomas. Adult type diffuse gliomas were simplified into 3 entities: astrocytoma IDH mutant, oligodendroglioma, which requires the IDH mutant and 1p19q codeletion, and glioblastoma IDH wild type. Previously, there were greater than 15 diffuse type gliomas. Now they are defined molecularly. A classic example of this definition, the molecular pathology superseding the morphology of histology, would be the oligoastrocytoma category. Those tumors showed mixed histological features and suffered from poor inter-observer reproducibility. Molecular testing demonstrated that most could definitely be classified as either astrocytoma or oligodendroglioma based on the IDH status. So that category, oligoastrocytoma, has basically been non-existent now with the emergence of molecular profiling. So this was basically some of the old classification, just to show the vast majority how it would have been. Changes with respect to glioblastoma. Basically, you could diagnose a glioblastoma even without necrosis or microvascular proliferation if molecular markers TERT promoter mutations present, EGFR amplification, or chromosome 7 minus 10 present. This was one of the most important updates in the CNS5. Changes in the astrocytoma grading. So astrocytoma IDH mutant is now graded CNSW grade WHO grade 2, 3, and 4. Of note, CDKN2A/B homogeneous deletion upgrades the tumor to grade 4, even without necrosis or microvascular proliferation. Also, we must note that the classic grade 1 tumors like pilocytic astrocytoma are biologically distinct IDH wild type and have been moved completely out of the diffuse glioma category into their own dedicated family called circumscribed astrocytic gliomas. This is a table here which helps understand arriving to the final diagnosis. So basically, the first line will show the histology. That will be the histological morphology. And then on the bottom of histology on the left-hand side, you'll see the various molecular markers and a flow chart of how they arrive to each diagnosis. This is also a flow diagram showing the old classification where, say for example, on the left-hand side, you'd have 3 different members of that family, basically, diffuse astrocytoma IDH mutant WHO grade 2, anaplastic astrocytoma glioblastoma, but now they have categorize all those as astrocytoma IDH mutant, WHO grades 2 to 4. One thing must be noted with respect to glioblastoma IDH wild type, that is on the extreme right, WHO grade 4. If there was a IDH wild type astrocytic tumor not fulfilling the or not meeting or having the other molecular markers, that would be classified as diffuse astrocytoma NEC, and that means not elsewhere classified because astrocytomas, they don't usually carry the IDH wild type. Pediatric type gliomas, they have been separated into low grade and high grade based on the molecular markers, and these are the names that follow. So the low grade being diffuse astrocytoma, angiocentric glioma, polymorphous, polymorphous low-grade neuroepithelial tumor of the young, diffuse low-grade glioma, high-grade being diffuse hemisphere glioma, diffuse midline glioma, diffuse pediatric type high-grade glioma, infant type hemispheric glioma. With respect to diffuse midline glioma, important terminology update must be noted. So previously, it would have been termed diffuse midline glioma H3 K27M mutant. However, now it is termed diffuse glioma, midline glioma H320 K27 altered. That is the case because although the mutation may not have taken place on H3K27M, K27, there may be other changes that bring about the same results. So the tumor will have the same aggressiveness despite not having a mutation on that chromosome specifically. So the term altered to specify that the tumor still has the aggressiveness, although it does not fall under the mutation on that point. Ependymomas now classified by location, histology, and molecular profile. Examples would be supratentorial ZFTA fusion positive or YAP1 fusion positive, posterior fossa PFA or PFB groups, spinal cord, often driven by NYCN amplification or classic histology, like mixed-up papillary. The classification or separation improves the prognostic accuracy. Medulloblastomas, previously there were four main subgroups: WNT activated, SHH activated, group 3, and group 4. That was from 2016 guidelines. 2021, WHO 5th edition introduced and refined updates to the system. The changes basically were the subdivision of the SHH group into separate age-defined and clinically distinct categories based on TP53 mutant versus TP53 wild type status, which heavily dictates the treatment resistance. It also further split the non-WNT and non-SHH tumors. It acknowledged that group 3 and 4 tumors actually represent a highly complex biological continuum, further dividing them into distinct subgroups, 1 to 8, based on DNA methylation patterns. They also mandated a dual layer nomenclature that every final medulloblastoma diagnosis uses dual layered system combining the molecular subgroup with a specific histological type. With respect to meningiomas, meningiomas are now classified as a single entity across the broad morphological spectrum of the 15 subtypes. There's uniform grading. Grade 2 and 3 criteria must be applied across all subtypes uniformly, meaning the molecular markers. Morphological de-escalation. So clear cell and choroidoid basically remain automatic grade 2 because of their high recurrence rate. However, papillary and rhabdoid categories no longer are an automatic grade 3 based on the fact that they need to to correlate with the molecular markers as well. Automatic grade 3 factors would be the presence of TRT promoter mutation or the CDKN2A/B homozygous deletion. Pineal gland tumor updates, shifting again to molecular subtyping. So the highly aggressive grade 4 pineoblastoma is now divided into specific molecular subgroups, primarily based on the molecular profiling. Also, CNS5 introduced a new subtype being desmoplastic myxoid tumor of the pineal region. The spectrum would be pineocytoma, WHO grade 1, pineal parenchymal tumor of intermediate differentiation, grade 2 or 3, pineoblastoma, grade 4. Tumors of the cellular region and pituitary updates. So we mentioned before, PIT1, PIT, SF1. Basically, this was, well, PIT net pituitary neuroendocrine tumors. This tumors added on to pituitary adenomas to enforce the neuroendocrine activity of the tumors, and we could correlate the lineage with in relation to the hormones produced. Updates in the mesenchymal and non-meningothelial tumors. So there's a consolidation of hemangioperiocytoma and solitary fibrous tumors into solitary fibrous tumor. This was anchored by the presence of the pathognomonic NAB2 STAT6 gene fusion. While the name aligns with soft tissue, the unique treated CNS gradient scheme remains a site for associated difference. 3 new entity additions were noted: intracranial mesenchymal tumor, CIC-arranged sarcoma, primary intracranial sarcoma. So it also brought about scope streamlining, where pure soft tissue variants that rarely appear in the CNS, such as leiomyoma, have been completely removed from the CNS volume. Updates on nerve tumors, paraganglioma reclassification. It was reclassified into the nerve tumor family or into the neuroendocrine region. Should be noted that the quadriquina or filum terminale paraganglioma, now recognized as a distinct standalone tumor type from other systemic sites due to unique DNA methylation profiles. The previous melanotic schwannoma, the new name is now malignant melanotic nerve sheath tumor, and the shift was to separate it basically from classic schwannomas due to its highly distinct and frequently aggressive nature. There's a new subtype in neurofibromas as well, atypical neurofibromatous neoplasm of unknown biological potential. The clinical meaning, a critical missing link or transitional entity in NF1 patients showing worrisome signs of malignant transformation, but insufficient for definitive diagnosis of malignant peripheral nerve sheath tumors. So this is a table showing the grades of the various tumors which we have spoken about. To note, meningioma goes up to same 1 to 3. Astrocytoma, IDH mutant, as we said, goes from 2 to 4, and glioblastoma wild type being 4. This is a matrix which essentially highlights the new additions and the from CNS5, as well as the redistribution of some of the tumors. They are highlighted in gray. And this was newly recognized tumors as in a table form. And this was where they were reorganized or revised nomenclature. So those would be in the matrix as well. So the major changes from the CNS5 were the separation of the pediatric type diffuse gliomas from adult type diffuse gliomas, the assignment of Arabic CNS WHO grades within the tumor types, the changing of the name diffuse midline glioma H3K27 mutant M mutant into diffuse midline glioma H3K27 altered, recognition of several new ependymal, embryonal, and other tumor types, and the upgrading of a tumor to glioblastoma based on molecular markers even without the presence of necrosis. Also, one of the main things being layered or integrated reporting, where it should include the histological classification as well as the molecular findings, as well as the WHO grade. And one of the main factors that drove this as well being the DNA methylation profiling, it being a emerging diagnostic tool used especially for difficult tumors, ambiguous histology, and for subclassification. The advantages are that it's highly reproducible. One thing that we spoke on earlier that I wanted to expand on as well was the use of NEC. Basically, not elsewhere classified would be that it did all the molecular testing successfully. However, it didn't match any of the known official entities. So that would be where it would be not elsewhere classified. Not otherwise specified would be that the molecular testing was not performed or it was failed due to the sample being insufficient or something like that. And therefore, or if the facility is not available, therefore you'd put not otherwise specified. And concluding, the WHO CNS5 represents a paradigm shift from morphology-based neuropathology towards biologically and molecularly defined CNS tumor entities, improving diagnostic precision, prognostication, and therapeutic stratification. These are my references. Thank you.